طب اوكي هم مظبطين.
Today, this is session 15, musculoskeletal imaging, high resolution imaging of small joints and fine structures, magnifying the details. The first speaker is Dr. Ahmed Wafaei, Professor of Radiology, Cairo University. The topic is temporomandibular joints in focus.
Good afternoon, everybody. I would like first to thank the organizing committee for inviting me here. And also thanks to Dr. Rania for the very nice invitation. I will have a short lecture about the temporomandibular joint. Nothing to disclose. The learning objectives are normal anatomy, radiological examination, especially of the MRI, different pathologies of the temporomandibular joints, including joint dysfunction, trauma, fractures, inflammation, infection, osteoarthritis, and tips for good image quality and accurate diagnosis. Temporomandibular joint is a synovial joint between the mandibular condyle and mandibular fossa eminence of the temporal bone. It allows for different types of movements, including rotation, protraction, retraction, and gliding. The most important intrinsic ligament is the lateral ligament, which is seen here in green, which strengthens the lateral side of the capsule. And we have two other extrinsic ligaments, which are the sphenomandibular ligaments, here in blue, and stylomandibular ligaments in red. These are the extrinsic ligaments, who are less important than the lateral ligament, which is the major intrinsic ligament. The most important structure of the joint is the intra-articular disc. The intra-articular disc is a biconcave fibrocartilaginous structure having a bow tie appearance and consists of a thick anterior band and thick posterior band with a narrow intermediate zone in between. And we have here the retrodiscal bilaminar zone, which is attached to the posterior capsule of the joint. The disc itself is blended with the anterior, lateral, and medial aspect of the joint, and is separated only from the posterior part of the capsule by this bilaminar stretchable zone, which allows for the movement of the disc between the closed mouth and open mouth. This moving diagram shows the movements of the joint between the open and the closed mouth. Please concentrate on the temporomandibular intra-articular disc in blue. There are two important factors in imaging. Number one is the posterior band of the intra-articular disc should lie at the summit of the mandibular head in closed mouth, and then the disc glides anteriorly in open mouth, with the narrow intermediate zone is always between the mandibular head and temporal bone in the narrowest portion of the joint. Thus, the intermediate zone consists or constitutes the point of rotation in the joint between open and closed mouth. We will discuss the different radiological examinations, including plain X-ray, CT, and most importantly, MRI, as I've said. X-rays are done in oblique views in open and closed mouth. It helps to identify the articular relations of the joint, any major bony changes, major fractures, and gross osteoarthritis. The CT scan should be done in a high resolution thin sections, 0.5 millimeter. We can reconstruct, of course, above 0.5 millimeter, but this is the typically done for high resolution imaging. Then we construct the images in coronal, sagittal, and 3D. And 3D is very important in TMJ. I will show why. And we do it in bone and soft tissue window, and it allows for identification of the bony details of the joint, like fractures, minor fractures, early osteoarthritis. And of course, we should do both joints at the same time. And in temporomandibular joint evaluation, whether CT and MRI, the two joints must be done at the same time. And one of the important diagnostic factors is to compare the right to left to identify and to be sure about the diagnostic outcome. MRI should be done in 1.5T or better 3T. 3T, of course, is better because it gives us a higher signal-to-noise ratio. 2 to 3 millimeter is the typical slice thickness. The field of view is 12 to 15 centimeter. A matrix should not be less than 265, next 2 to 4, and it is done in open mouse and closed mouse using a bite block, because the bite block keeps the mouse in open and closed mouse, and we can avoid by this the motion artifacts. And it's better to do the MRI examination using a dedicated surface coil. This is the best. But also we can do it using a multi-channel head coil or small extremity flex coil, but be sure that the coil is fixed and positioned typically and symmetrically between the right and left side. Sequences are T1, proton density fat sat, and the stir. This is the typical sequence in our institution. We can do it also a dynamic CENI for the joint when we do the examination in closed and different open mouth grades. And we use IV contrast in case of inflammation and infection. TMJ dysfunction is the most common complication and most common pathology that we are seek diagnosis by MRI for this dysfunction. It's an abnormal rotation between the disc and the articular surface. It's more common in females. Female to male ratio is 8 to 1. Patient complains of pain, clicking, and functional restriction. The internal derangement types are either anterior disc displacement is the most common, whether reducible or non-reducible, and posterior disc displacement is uncommon. It means that the posterior band lies posteriorly beyond 1 o'clock position behind the summit of the head. And the third rare type of internal derangement was called a stuck disc, means that the disc is fixed and not displaceable between the closed and open mouth views due to intra-articular adhesions. Here is the first case of a female patient complaining of a pain and clicking of the right side of the right temporomandibular joint. This is a closed mouth view. We can see that the disc is displaced anteriorly. We can place a line traversing the head of the mandible. The disc is typically located in front of the line, so it's displaced anteriorly. And in open mouth, the range of translation of the head, the head moves anteriorly to lie beneath the eminence and recapture with the disc, producing a click, and this is the cause of clicking of the joint in this mild type 1 dysfunction. So this is the pathology, this reducible anterior disc dislocation. Similarly, in this case, we can notice that the disc is located, the biconcave disc is located in front of the head, so it is placed anteriorly in open mouth, in closed mouth. And in open mouth, we can see the motion here. In open mouth, it is displaced anteriorly and non-reducible with decreased range of translation. The head is not at the bottom of the eminence, so it's regressed posterior. So we have a reduced range of motion of the joint. So this is another type of anterior, non-reducible anterior disc displacement. This is a patient complaining of chronic left-sided pain of the temporomandibular joint with dysfunction and reduced range of motion. We can see here the disc is deformed, showing heterogeneous high signal intensity and displaced anteriorly, and it just moved a little in open mouth compared to the closed mouth. Also, there is distension of the posterior part of the joint with mild adhesions posteriorly. So this is a non-reducible anterior disc displacement with somewhat stuck disc in an anterior position. Other TMJ pathologies include fracture dislocations. This is the importance of the multi-detector CT, as I've said before. We should do a CT in a very small reconstruction with sagittal, coronal, and 3D. we can see that the head is displaced anteriorly, and there's a displaced fracture of the mandibular neck here. And in axial view, we can see an empty mandibular fossa. In comparison to the right side, here is the head, but here the head is absent due to anterior dislocation anteriorly beneath the mandibular eminence. 3D reconstruction is very important. I advise everyone is reporting a small joint like this must do a 3D. It's very easy to reconstruct in workstation because it's easy to depict a small fracture, even if not displaced in 3D, rather than to be messed in regular CT sections, which are very many sections that can be messed in between these sections. The fractures of the temporomandibular joint, like any other joint, we may have an intra-articular fracture. Intra-articular fracture means the fracture extends within the articular surface, like the fracture here, or extra-articular fractures within the mandibular neck, whether it's high, middle, or low. This is the regular classification. Osteoarthritis is very important pathology for the temporomandibular joint. This is a CT showing as regular osteoarthritis. We have a narrow joint space, osteophytes, subcondylar sclerosis, small loose bodies and posterior aspects of the joints. This is typical osteoarthritis. And here is a case of MRI showing another osteoarthritis with an anterior osteophytes, abnormal remodeling of the mandibular head, and subcondylar sclerosis flow signal, but the disc still maintains its normal shape and signal intensity and normal position. Osteoarthritis is very important because it is a consequence, it might be a consequence of TMJ dysfunction, and in long-standing cases of dysfunction without osteoarthritis, the end result may be a complicating osteoarthritis after years of neglected TMJ dysfunction. It's important to remember that TMJ is a synovial joint, so it's subjected to inflammation and infection. You must remember this. This is a case of inflammation of temporomandibular joint showing joint effusion outlining the intra-articular disc. And this is a case of juvenile idiopathic arthritis showing enhancing T1 fat set post-contrast, showing enhancing synovial thickening and enhancing bone marrow with remodeled head, denoting long-standing case of osteoarthritis with mandibular head erosion and marrow edema and enhancement. Our take-home points are: MRI is the best modality to evaluate TMJ dysfunction, optimized scan parameters, and right-to-left comparison is very important to consolidate our confidence in diagnosis. CT is a modality of choice in the setting of trauma and fractures. Please look for sagittal, coronary reconstruction, and 3D in order not to miss a minor non-displaced fracture. And remember, TMJ is a synovial joint, so it's subjected to joint synovitis and arthritis, especially in the context of polyarthropathy. Please remember, TMJ could be affected. Osteoarthritis is very important TMJ pathology, whether a cause of TMJ dysfunction or a complication of long-standing dysfunction. Here's my references. Thank you.